Hey guys, it's the Doc, and we are throwing it back in this week's Cyst video. There was like a short period, well, it was maybe a little bit of a longer period, where YouTube was essentially shadow banning my content. My surgical procedures were deemed, not fit for most audiences, and I was actually forced through YouTube's recommendation actually to make a membership area to show my surgical videos. And there's a lot of great content on there that, folks, honestly, like very few folks actually saw. So what we're gonna be doing is we're gonna be bringing some of that content back, and we're gonna just do some reaction videos where I'm just kind of doing some voiceover on the procedure, giving you some, commentary on why I do what I do and some of the logic behind all that. So let's dive right in. This video was actually from October, I think it was from October 2022. We removed a cyst from the top of my patient's foot. It was a very, very cool procedure, and let's dive right into it. So the first step is when the patient comes in, for the surgical procedure. I've consulted on this before, so I've seen the patient and said, okay, we're gonna schedule this surgical procedure. So the patient came in, and we know what we're about to do, so I block off enough time in my schedule to get that done. And the first step is just kind of palpating the cyst and kind of planning the attack. So that's kind of what I'm doing there. I'm kind of just like feeling around, cleaning the area up right now is what I'm doing. But I really like to feel the cyst and see, how large it is, because sometimes what you see at the surface is actually much larger underneath. And I like to mark the area, which is what I'm doing now. So I kind of just mark where the cyst is. In this case, it's a small cyst. I'm just putting a dot over the center of it. Because sometimes when you put the anesthesia in, particularly on an area like this, where the skin is very, very thin, the anesthesia makes the tissue swell and kind of distorts the anatomy. So I just like to mark where the center of the cyst is in this case, and that basically dictates where I'm going to make my incision, just in case the anatomy gets distorted by the anesthesia. So here I'm injecting the anesthesia. So the first few shots, the patient will feel. So I kind of, I inject pretty slowly, but I've seen comments where folks are like, I don't like the way this guy injects anesthesia, it's like too rough. The reason why I'm actually pretty fast after the first couple of shots is because the patient's actually already numb and they're not really feeling it. So I inject the anesthesia in, pretty quickly because, the patient's not really feeling any pain associated with it. I always try to go into an area that's already numb. So you'll kind of see me bouncing the needle around a bit, but I always go through a spot that's already been numb. So here I'm making my first incision, and you can see I'm actually using that little dot I made as a landmark, and I'm making a small ellipse here to try to get the cyst out. And generally my goal, I would say always my goal, is to get the cyst out of the smallest incision possible, because small incision leaves a small scar. So a lot of times I will see comments that say, oh, why'd you make the incision so small, or there's no way you're gonna get the cyst out of an incision that small. Sometimes I do have to extend the incision, but I always try to make the smallest incision possible initially and then try to get the cyst out of that, just because it'll be a better functional and cosmetic outcome for my patient. But sometimes, it's just not possible. And sometimes you will notice I do extend an incision just to facilitate the procedure. In this case, I don't think I had to do that. So here you can see I'm trying to dissecting the cyst out. So you can see the cyst wall just pop it out there. And I'm using some dissection scissors, I use the blunt side to kind of just spread the tissue around the cyst, and that actually enables me to extract it. So this first step is just kind of like dislodging it from, oh, there it goes, it popped. So these things are under pressure sometimes, and just when I'm doing the dissection, the cyst wall might rupture, which is the case here. But that blunt dissection enables me to do what I'm doing right now, is basically kind of just like squeeze the cyst out, pop it out. So this cyst is pretty much ready to come out. I'm grabbing onto the cyst with my forceps. It's a small little guy. And then I'm gonna try to dissect the bottom of the cyst out while holding it. So I just kind of maneuver the cyst around and just try to further dissect around it, snip away at some of the tissue that's around it. Sometimes these cysts have a little bit of scar tissue around it. In this case, I think this is just like normal collagen that's around the cyst. Sorry, we're blocking your view there. And there it is. So we're just kind of getting the last little strip of fibrous tissue out, and the cyst is gone. So this was pretty quick and easy. I do frequently just kind of, check around just to make sure there's no remnants of cyst wall remaining. There I'm just trying to, just check to see how easily this will approximate. And this, this is pretty easy here. So putting some sutures in, think I did a mattress stitch here. Let me see. Actually, no, these are just simple interrupted stitches. This was really, really tiny. So I just used a couple of stitches. There's my first one. I usually like to do the first stitch in the middle just to see how well everything approximates. Then I'll put the sutures lateral to that to fully close up the wound. This one probably only needed like about 3 stitches, I would say. But I don't remember exactly, to be honest with you. So let's see what I did. So generally, like what I tell my patients is I do leave it like, I don't make the stitches super tight because I'm removing something that was occupying space in the skin. The body naturally will try to fill that void with blood and serum and stuff. And I want that to escape. So what I tell my patients, and I'm sure you've heard me say this a bunch of times, is you might notice a watery, bloody discharge for a couple of days. That's totally normal. But if you notice like pus or anything that seems out of the ordinary, give me a call. But a little bit of watery, bloody discharge for the first couple of days is totally normal. Sometimes that doesn't happen, but if it does happen, it's nothing to be worried about. Typically I have the pathology back the next day or in 2 days at the latest. So we always call our patients just to tell them that, hey, everything was fine. But we do use that as an opportunity to check in with them, say, is everything healing up okay? You doing all right? Feeling okay? And I tell my patients, if anything pops up between now, the time of surgery, and when you hear from me, when I call you with pathology, we're always available. So we're pretty easy to find. My patients can always call the office or shoot me an email or whatever. And we're very, very responsive to that sort of thing. But I think this guy had pretty easy peasy course for him. The stitches stay in for 2 weeks. My patients can shower, the stitches can get wet, but what I do advise them to do is put some Vaseline or Aquaphor over the stitches just to keep the wound moist and just facilitates healing. I don't like bacitracin or Neosporin, which are over-the-counter topical antibiotics, because they frequently cause contact allergy in patients, and that just kind of muddies their recovery. So I must not have liked the way that stitch was because I pulled it out. I get a little anal with the stitch placement. So sometimes you'll see me kind of just like pull a stitch out if I don't like exactly where it is. And I think that's what I did there. So this one hopefully I'll like better. It looks like I do. This is probably the last one, just tying this last knot. So this patient did very, very well. The stitches stayed in for 2 weeks. We took him out, and then he was basically back up and running. First, for a cyst like this, there honestly is really not much downtime. And in fact, this guy, really no limitations. Because of where that cyst is, it's really under no tension at all. So even if you want to like work out or whatever, there's really no issue with where that is. So in a case like this, I would just tell my patient, hey, you can do whatever you feel comfortable doing. Just be mindful of the fact that you do have stitches there and you don't want them to pop. But these will be pretty tough to pop just because they're not really under a ton of tension at the top of the foot. So that's that cyst. I hope you guys enjoy it. If you have any questions, please drop them in the comments below and I'll be more than happy to answer them. As you know, I love answering and responding to comments, the kind ones. But I appreciate all you guys. I love the way this community is growing. I love all the new subscribers that have joined the channel. I truly appreciate you guys, appreciate your support. And most of all, I appreciate this wonderful community of positivity we're creating. Let's get it.